So welcome, Dr. Hao.
Hello. Thank you very much, Rolando. Good morning, good afternoon, good evening for everyone, wherever you are in the world. Here is a very warm greeting from Malaysia. So my name is Hao Kim Chuan, or you can call me KC Hao. So today I'm very honored to be invited by Megagen to share with you my limited experience in immediate extraction, immediate implant, and provisionalization using the R2Gate system. So as what Rolando has said that now is a time during coronavirus, we want to be able to save time. And most importantly, is not time saving, is actually the accuracy delivery of the treatment outcome. So just a little bit about myself. I graduated from Singapore. I'm a qualified orthodontist from London. I'm also an oral surgeon from the Royal College of Surgeons of England, as well as Edinburgh and Glasgow. And I also have oral implantology from Frankfurt, Bern, as well as a diplomat in International Congress of Oral Implantologists. So this is a little bit about myself. All right, so I'm also very honored to be appointed as a MINET Honor member. All right, so now today we're going to talk about how we can use the photonic technology into delivering prosthodontically driven implant philosophy. So as we all know that, right, implant, we used to place implant wherever the bones is available. But right now, we actually retrofit it by planning with the prosthodontics in mind, and then to then work backwards to place our implant into the correct position. And if bone grafting is required, then we shall perform bone grafting accordingly. So now, if we look back into all the implant system that has been developed for all these years, then we know that there are many, many different sizes for different regions in the oral cavity. Now, how do we actually know what sizes and what length to use it? So usually we just take an x-ray before that. But right now, in the prosthodontically implant philosophy, we want to be able to know the sizes well before we even started the treatment. So how we can use this technology to help us to deliver all these results very predictably, inclusive of not just the fixture itself, but also the abutment connection, which we can make it a fully customized abutment, plus also a 3D printed prosthodontic in terms of the crown and the prosthesis, that we are now into the full digital technology into doing this. So the keyword right now is digital and fully customized abutment, as well as the 3D printed crown. Right. So now go back a little bit about history, about 15 to 20 years ago. When we were to do an implant, we usually have to take a study model, then we set it up, and then we make a diagnostic wax up, and then we start planning the implant position, and then we make a surgical guide by doing that. So this is very time consuming. So back in about 10 years ago, we then developed the dental cone beam CT, which is being popularized, and we start using the cone beam CT to plan our surgical guide, which is of course a lot more accurate. And this, we are moving into a DICOM file technology. So, but yet we still have a lot of problem. It's because not only is the cost, but also the time. Plus, ultimately, there's also the inaccuracy. So let's review one of two systems of the first generation of CBCT-based guided system. So the one that is quite well known is Anatomage, or Nobel Biocare, or Simplant, or Sirona SciCat here. So we just name, say, for example, Nobel Guide, for example. So we know that Nobel Guide has actually come up with a system that is about 2005, which is about 15 years ago. Now, so let's evaluate objectively what was the problem of first generation of the guides, of surgical guide. So first thing is that it is multiple visit. As a first visit, you need to take an impression, then you take about 15 days to develop the guide. After that, you need to then ask the patient to come second visit to take a CBCT, and then you take 3 days to develop a surgical guide. Yeah, so the plan. After that, you have to make a surgical guide, which is not a 3D printing technology, where to use actually the fabrications, either a heat cure or a cold cure. Then only there we ask the patient to come in to place the surgery. So it's all very well if we were to spend, let's say, such a long time to plan for the surgery, but the problem is that not only is complicated, time consuming, also increase the cost, and the worst thing of all is that it's lacking the precision in surgery. So therefore, after 15 years, it has never been very popular because of all these problems that we just stated. So now, so the problem with CBCT is that, right, no matter what system of CBCT that we are talking about 200 microns of the inaccuracy here. So say, for example, if we have a CBCT image here, now we use a bone as a boundary. If you take in you just take a look at the CBCT, at first you can see like that. Now, so if we now actually magnify again and magnify bigger and bigger, so we begin to see that it's very difficult for us now to differentiate between the bone outline as well as the teeth outline. So this actually poses a lot of inaccuracy. So when we are planning, if we cannot actually identify with high precision where exactly is a bone outline, then we will have difficulty in placing the implant in the correct position. So let's look back in the history about how CBCT work, all right, and what are the problems with it. So first of all, we need to actually give tribute to Godfrey Hounsfield as well as Alan Cormack, who is actually the Nobel Prize in Medicine laureate in 1979. So we're talking about 40 years ago. So what they did was that they used a cone beam CT, and obviously they have a very big device and with a receptor here. And then, so what they did is that they cut it into circulate 360 degree, and with the acquisition of the image, then we do a reconstruction. So with this reconstruction, we then magnified it again into many, many different sections. And we now enlarge it again into units. So each of these units, we call one unit of voxel. Voxel means volume, all right? So if it's a 2D picture, we call it a pixel. But if it's 3D, we call it a volume element, which is a voxel. So with this voxel, the more voxel you have, the more so-called higher the resolution. So in this case, let's say we have 100 millions of voxel, and even with this magnification, we still cannot identify the bone very, very clearly. So in order to improve this one, let's examine Hounsfield. When Godfrey Hounsfield, how he identified it, right? He was using the distilled water at the standard pressure and the temperature, we call it a STP, to make it as a zero Hounsfield unit. So therefore, with that, air will become minus 1000, whereas that the solid bone will become plus 4000 Hounsfield unit. So what's the problem with this is that, right, we usually have very unclear and undefined soft tissue and hard tissue boundary. Now, the problem is that, right, most of the CBCT using the 250 shades of black and white, but then our human eye, honestly speaking, can only detect 16 shades of the 256 shades, which means that it's only 6% that's visible to our human eye. So therefore, in order to solve this problem, instead of using the 250 shades of black and white, why don't we use a color to help us? So therefore, we now assign A as a total black color. And then if it's a soft tissue, we use a red color. If it's between soft tissue and the cartilage bone or the softer bone, then we use a blue color. And then once you come to the harder bone, we use a yellow or orange color. And then when it comes to the teeth, become green color. So with all this color definition, we then use the word called digital eye. So digital eye is helping us to be able to identify which is a teeth, which is a soft tissue, and which is a bone, and then which is actually air. So with that, right, we are much able to identify it a lot clearer compared to the original Hounsfield unit. And that thanks to R2Gate, we call it a digital eye innovation. So with this digital innovation, right, obviously it helps us to be able to identify this red as a soft tissue, green as a teeth, and then orange or yellow as a bone. Right. So with this inclination, we now will be able to more accurately define it. But however, no matter how we do it, we still find that the DICOM file still has certain limitation. So now that comes with what we call the STL file. We call it the standard tessellation language. So what's STL file? Basically, we can come into two formats. One is that actually you can use it a model scanner that you can put it into here, and we can actually use a model scanner to scan the whole thing, which is available in most of the laboratory. Or in the clinical setup, we usually use an intraoral scanner. So once you scan the image, we can then be able to obtain the STL file. So what's the advantage of STL files is that it gives us the accuracy of under 10 to 30 microns, depending on the make of the scanner. So let's compare a DICOM file, which has an accuracy of about 200 microns. Now we have STL file, which has 10 to 30 microns. So it's definitely a much significant improvement. So therefore, what does R2Gate do is that if we have the CBCT plus the STL file, can we actually merge these two together and create a hybrid image, which will give us the best of both worlds of the CBCT as well as the STL file? Because we know that intraoral scanner cannot actually perform the 3D X-ray. So a 3D X-ray can only come in a DICOM file, which is digital imaging and communications in medicine. So we now have a DICOM and a STL, then we can actually make it into a common platform. We call it a hybrid file. So in order to do that, right, how can we actually do this is that we now can use a CBCT with a digital eye, and then we also can use the STL, where we can take a model and then together with this with a scan. Then after that, we also do an intraoral scanning of the teeth, and finally we can produce a STL precision. And therefore, using this hybrid file, we now use it to plan our implant positioning. So which means that our precision error is down to only 10 to 30 microns. All right. So how do we do this? We are going to share with you a clinical case on how we can actually achieve this one. So now, let's say now if we're supposing that now we have solved this one as CBCT, we know that we have the DICOM file. So when we actually get the final file, when we know that our precision is under 30 microns, we can now plan a position. And now in order to produce this guide, if we were to use a conventional laboratory system to actually produce this one, we again has the error of the shrinkage of the acrylic. But if we were to use a 3D printing technology, again, our precision is a lot higher. Now, the next thing is that if we were to use the design of the prosthesis, now, so assuming that we have to switch from one software to another software by conversion, again, we'll lose some precision. But assuming that we actually have a single platform software that allow us from CBCT to surgical guide to 3D printing to design processes and final manufacturing, all under a single software system, which means that we do not have to switch from one platform to the next. That will give us an accuracy of under 10 microns. So this is exactly what R2Gate software system is all about. So let's share with you about this system in some of the clinical cases. All right. So now, first of all, I also like to acknowledge my good friend, who is also the CEO of Megagen, Professor Park Kwan-Boon. Right. He actually discussed with me and invited me to Megagen Center there in Daegu. So we actually like to share about his system. And I also want to share with you one very exciting future is that as an orthodontist, assuming that if I were to move the teeth digitally, and at the end of the day, I wish to put the implant, can I also, before I started my orthodontic, plan for my implant and then also be able to produce the final position? So this sounds quite impossible in the beginning, but I can tell you that it is a reality right now for all of us. So as an orthodontist, as well as a dentist oral surgeon who place implant, I will actually very excited to share with you this new technology. Okay, now let's look into how we can export the STL file accurately and to designing it. And also let's look into the study to show that how accurate is our precision. In the anterior section, it's down to 0.05, that means 5 microns. In the posterior, is 7 microns, which means that we now achieve a precision of under 10 microns. For the anterior region, we are as accurate as only 5 microns. So let's go back to prosthodontically driven philosophy again. Right. So we have a case here that we want to discuss with you. That a Caucasian of British or nationality, 54 years old, complaining of pain and swelling on a retreated root canal. He's seen many dentists before but could not identify the source of the pain and the problem. So this is how the patient presented to us, that he has a swelling and pain between 1, 2 and 1, 1. All right, so, and then if we were to examine it intraorally, then we can see that there's a swelling with a sinus discharge on the labial surface. On the palatal, there is no swelling. And now if we were to look into our clinical investigation, it is actually corresponding to 1, 2. So if we take OPG, we only can see that the root field is short. But if we now look into the PA, and we can see there seems to be a PA lesion, which is connecting 1, 2 and 1, 1. So now if we take a CBCT, all right, and then we take a closer look, we now see that there's actually a PA lesion on both the frontal as well as the sagittal surface. Now, if we magnify it further again, then we now see that not only a PA lesion, but also a fracture root. Yeah. So we now understand the why is that there is actually a swelling which went unidentified, because the fracture root was not seen in the normal 2D X-ray. So despite repeated root canal retreatment, and it has not been able to identify. So if we now look into the 3D from both coronal view as well as the occlusal view, obviously we see that it developed into a large PA lesion. So when we see such a large PA lesion, we need to actually be very mindful that it is not just a pus. It is most likely a granuloma, periapical granuloma formation. So what's the significance in terms of placing implants is that having extracted, we need to make sure that we fully enucleated or we remove the granuloma, because if we don't do that, that will be one of the cause for the implant failure. Okay, so now with this one, so we now have to walk you through how do we plan for the our treatment plan, as well as walk you through on our R2Gate. So our treatment plans is that we want to use the R2Gate system. We need to extract, of course, we remove the periapical granuloma, and then we use the R2Gate drilling system, drilling sequence. Then we are going to place a fixture, and we have a target of primary stability of at least 55 Newton, right? So what are the factors to consider? First factor is mucosal thickness, which we talk about gingival biotype. The second is aesthetic concern. Third is the bone level. And the fourth is the whether it's D1, D2, D3, D4, the bone type as a bone density. Yeah. So with that, the first thing that we talked about is actually a gingival biotype. All right. So Oxenbian and Ross actually classified it. The biotype can be either the thin or the thick gingival tissue. So to make it simpler, that if it's a shallow and thin one, we call the thin biotype. And if it's a flat and thick one, then we call it a thick biotype. So with the thick biotype, obviously, we will have a much better aesthetic, and there will be lesser soft gingival recession. So in this case, we are looking into first a biotype. The first is that we are very happy that we actually have a thick gingival biotype. Then secondly is that when you look into the lip line, unfortunately, this patient has very high lip line. So which means that our margin as well as aesthetic challenge will be a lot higher. And when it comes to the bone level, we're happy that we have sufficient bone height. However, when it comes to the bone density, we're set that this is actually a D3 or D4 bone, mainly due to the infection. All right. So now with the R2Gate planning, the first thing that we need to know is that what are the science behind the R2Gate planning? So the accuracy of merging, that is the first test that we need to do. So how reliable is our conversion technology? And how do we do the auto merging? And how can we trust this technology 100%? So first of all, right, we need to know that if we are able to have a much bigger surface area of superimposition, that we have such a big area of merging the soft tissue as well as the hard tissue, that means, right, our accuracy of superimposition of the STL plus the CBCT diconfile will be very accurate, up to about less than 5 microns. So in order to achieve this one, we can actually use the R2 tray. So the advantage of the R2 tray, not only that it gives you a very large surface area of superimposition, but it also takes care of the metal scattering effect, which is usually when you take an X-ray, you find that it just scatters. But the moment you use the R2 tray, it's radio opaque. It does not scatter at all. So which will means that our image, right, will be super accurate. So now, if we look at the most of the CBCT system, once there is such a scattering effect, we're not able to identify where exactly is the bone, where exactly is the teeth. We can't even identify the crown margin. But assuming that we now use R2Gate tray, which is a radio opaque, then we can actually effectively shield the metal scattering effect. All right. So what's the next thing that we do? Let me walk through with you this video. Then we will be able to share to you what are the advantages for that. So now, first of all, we actually do that. Then whether it's a partially dentate or not, if the patient has a lot of metal, whether it's amalgam filling or crown and bridges, right? This is when we need to use the R2 tray. And what you see here is actually R2 tray here. This R2 tray here, first of all, of course, you try to fit it. Yeah, and then after that, what we then do is that we would then put some adhesive, and with this adhesive, then we then use impression material, and then we now take such an impression material inside the mouth and ensure the stability. After that, when we actually have taken it with this material, then we now ask the patient to actually wear this one and then to then take a CBCT with this material around. So with this, then we know that we have actually effectively shoo away the metal scattering. And then what we then do is that with this study model that we have, we can produce a STL file with the model scanner. So now the model scanner will be a STL file, whereas a CBCT will give you a DICOM file, and then we already have sufficient information to merge these two together. So by able to merge these two together, we'll be able to produce such an image that we can see now this is a tray outline, and then this is a teeth outline, and this is actually the bone out, the soft tissue outline, and this is the bone outline. So everything is so superimpositional, impositionable, and then they are so accurate. So with this so-called merging effect, we will achieve a precision of about 5 microns of error only. So with 5 microns of error, that means it's 5/1000 of a millimeter. We can be very sure that whatever we plan is what you see is what you get. Okay, so now let's also look into the effects of the vertical positioning by Dennis Tarnow in his very famous publications, right? So what he's saying is that, right, if we are able to achieve a vertical positioning here, but our problem is that very often if we cannot see where is a labial vertical or palatal vertical, we usually have to guess. But now with this position, we can actually plan it very accurately, and we can plan it in such a way that if this is the vertical level that we want to plan, then we can plan it just about 1 millimeter below the bone level. And then what about from the vertical height? What Dennis Tarnow says is that if you know where is actually the gingival papilla, you can plan 5 millimeter below the gingival papilla. And if you cannot see the gingival papilla, at least you can see the crestal bone. You plan 3 millimeter below the most pointed crestal bone. Okay, then you might ask, what about the buccal labial thickness? As we know that for maximum aesthetic, we need about 2 millimeter of buccal bone and at least 1 millimeter of palatal bone. So we can also plan it very accurately. And then of course, you may ask also, how much space do we need between the two implants? All right, and how much we need to place between implant and tooth. So most of the international literature says that if you have an implant and a natural tooth, they should be at least 1.5 to 2 millimeter apart from the horizontal distance. And if an implant to implant, it should be at least 3 millimeter. So now with R2Gate, with this merging of the file, we can see all these things very, very clearly with our digital eye. And therefore, we can plan it very, very closely and precisely within 5 microns of error. So now, with this, we can now also start planning for our abutment. So abutment, assuming that I place my implant at this position, then my software is telling me that I need 29 degrees of angle abutment corrections. But I don't like it because I don't want such a large degree of angle correction. So what then I have to do is that I can actually adjust my implant slightly more palatal. So I place it more palatal, which also will be better because my labial bone is very thin. So with this positioning, now I only require 18.9 degree of angle correction, and yet I'm still able to do a screw retain on the palatal position. So therefore, it not only allows me to see my labial and palatal bone very clearly, it also allows me to plan what sort of angle abutment that I require to ensure that I can still achieve a screw retain abutment. Right, so therefore, I will happy with this. And the next thing is that it's a bone analysis. So now, if we were to analyze the bone here, and we now know that the air is actually black in color, and with this, we know that this is actually the bone thickness here, and my implant is going to place here. My implant will be leaning against my palatal bone and leave my labial bone free. So I then know that there's going to be some defects here, which will then allows me to do some bone grafting to prevent any further bone resorption. So I already know that I require some bone grafting prior to going for the surgery. So I can actually prepare it and also inform the patient that some bone grafting will be necessary, and we can all build all these things into the consent for surgery before that. And finally, we have such a plan, then we can actually discuss this with the patient so patient understand exactly what it's all about, and before we proceed with the treatment. And so when the patient agree, we then use a 3D printing technology to print out our surgical guide. So once print out a surgical guide, we now need to actually examine how precise is our surgical guide and how predictable is our drill sequence in order to achieve this result with no error. Because many a times, we may be able to plan very well in our planning, but when it comes to delivery, we may have a problem. So over here, I want to quote one of my good friends, Professor Park Ji-man, right, whose publication talking about the clearance between drilling and bushing of various implant guide system. So his conclusions is that, right, the error can be as little as 0.94 degree, which is less than 1 degree, or as much as 7.8 degree of the surgical guide variation. And R2Gate system was significantly smaller than other systems. So this Professor Park, whom I have met with him earlier this year, and I also have the privilege to invite him to Malaysia last year as our speaker. Yeah, so, and this is his conclusion here. He has very kindly given me the permission to actually discuss about his article. Right, so now let's visit the drilling sequence here. Now, very funny is that you see that this R2Gate drilling system is that we actually started from a very small drill, very short one, and then progressively get longer. So this is like a root canal system. We call it a step back technique. We step back by actually using a bigger one, bigger diameter, and then later we go deeper and deeper and into the final depth that we want, okay, or step down technique. Huh? Okay, so now with this, right, we find that the first drill we drill is here. Then there is actually a stopper here to enable us to know the exact depth that we need to drill into. So you notice that all the drill comes to a stopper and with a surgical guide here. So therefore, our vertical drilling depth is actually being assured. And so, and this is why we are not worried about that there will be an error during the drilling. And also the drilling speed. When you are in the beginning, you drill at 1,000, then after that reduce to 500. In fact, when I come to insertion here, I go as low as actually 30 RPM. All right, so let's look into it. What are the possible error factors from the computer assisted surgery? We call it CAS. All right, so now this will be a problem if you actually have a thin ridge as well extraction socket. Now the J.C. Kim's lecture and as well as his publication shows that if let's say we plan a surgical guide supposedly like this one, sometimes we end up actually having some deficiency either from a labia or we may be tilting in an angle. What was the cause of the reason? Say for example, if we were to drill, right, and because there's a palatal bone here and here is thinner, here is thicker, so very likely that we're being forced to tip into this way in the drilling sequence. It just slip of the burr, and the moment you slip out of it, we actually perforated from here, which will be a gone case already. So how do we actually avoid this problem using the R2Gate guide is that, assuming this is a pathway of our planning, so the rule number one is that we must use the bone at least 5 mm. That means you must have actually a length here for at least 5 mm of drilling it. That's why we have to drill it at a short drill first. Then the second rule is that we have to cut away the corona here and the step back drilling technique. And then the third rule is that we actually have to cut the palatal bone first before we allow it to push it over to the labia. So this is how we actually achieve during this one to avoid the drilling slippage of the drill, which we call it a bushing or slippage. All right. So here you can see that we go on the stepwise. That one is 5, then release to the left hand 1, that one is 5, and to the minus relax that is 1. Then now we go up to the next down, 7.5, and then 3.8, we go to 7 and 8. Then we go up and down, and finally we go and we achieve a predictable torque, insertion torque that we want. So,
sorry, Dr. Hao,
yes?
the music was so loud, so it wasn't possible to hear what you were commenting.
I'm so sorry. Okay,
Yeah.
so, all right. So, never mind. So I will just repeat again. All right. So what I'm just saying is that you will see that first is that we use this drill, which is actually a soft tissue remover. Then after that, we drill into our cortical bone. Yeah, at a very short length, we penetrate to the cortical bone. Then we go deeper by up to 7 mm. Then we go stepwise from 2 mm all the way to the desired length that we want. Let's say 30 mm. From 30 mm, 2 by 30 mm, we move to 2.5, then 2.8, and 3.3. So 3.3, right? Assuming this is our final size, is 3.5. Then we go stepwise again from 7, 8.5, 10, 11.5, and 30 mm. That's how we do it, right? Okay, so let me show you again how we can do it in another video again. So this is a one-day implant will make it effective. So in fact, nowadays, we don't even use the word one day, we use 1 hour implant restoration. So how we use it also that in order to make things easier, we actually develop a tablet form that enables us to directly. So this will give you a summary. So first of all, we use the standardization of the CBCT. Then whichever CBCT system that you use, we are able to convert it into a hybrid file, and therefore the accuracy will be enhanced. So it doesn't matter which system of CBCT that you're using, we are able to actually use software to optimize the resolution. Yeah. And once it's planned already, if that the technician plan, you actually have there's an app you can download. You can actually do the planning as well as the approval process in the software, and you're happy with that, you can just tell the technician just to use a 3D printer. Yeah. So this is
turning imagination into reality. R2Gate
in the world. All right. So this is just a tablet format, right? So that's just to say anytime and anywhere.
See the light of a new day dawning.
You do the planning.
Feel the light from a beating heart.
When you receive give a message
Catch a ride to the top of the world.
that the plan is ready for your approval by your laboratory.
And it's good to be alive. It's good to be alive. This feeling's running high. Life is calling.
So wherever you are,
It's beautiful.
and once you pick up the and you can then go back to your clinic to
Wherever you are with the R2Gate light, you are already at the clinic.
We are not restricted by the time and space anymore. Okay, so now we come back to just now the patient again. How do we do it? So we actually printed a 3D printing, and then we also selected our abutment, our key, as well as printed our provisional crown. Right, so I'm sorry. So with this, we give the local anesthesia and we extracted the tooth, one tooth, not two, but just a different surface. So having extracted, we now curate touch the enucleate the granuloma, and after that we take a PA just to ensure that we clean everything. All right, and with that we'll start our drilling sequence. Yeah, so and of course we know that there's a fracture here, and we are actually just to refresh our memory of all the things that we're doing, and now we can get to see the actual process. So first of all, we are talking about extraction and the granuloma here, and of course we are yeah, so and then we do a traumatic extraction. And of course we remove the movement. Then we create the granuloma and we fix in our 3D printed procedure guide and do our first drill. Then after that 2x7. Then we go deeper 8.5. Go deeper 10 millimeter. Go deeper 11.5. We go deeper to 13 millimeter. Then now we progress to a bigger diameter 2.5. We can go straight to 13 millimeter. And 2.8 we go straight to 13 millimeter. Then now we are going to go to our final. We go 7 again, 3.3 and 3.84 millimeter. Why? Because we want to create wider the cortical wall. And we are going to place the implant 4x13. So with this, then we use our hand torque to ensure that it's popping in. So our original plan was 55 Newton, but here we find that we can actually achieve up to 70 Nm, and then we have the ISP value of 74. Then we use power screw to power the whole first, and that put the bone graft so that the bone graft will not go into the picture itself. And with that, we pick up the power screw again. Then we insert our abutment, and then we still retain it. And after that, we use the special heat to make sure that it's 1 millimeter shorter, so that we do not actually bite onto it heavily. So at the end of it, because we have actually extracted and put it back, so we can fool our body in such a way that the body still do not realize that actually the tooth have been extracted. And what does that mean is that, right, technically speaking, if you can actually fool your body by inserting back the pressure, there will be very minimum frontal bone resorption. And this has been proven in many literature, but of course more study has yet to be established to actually show that immediate implant and immediate provisionalization with sufficient torque and also pressure to support the apical tissue will be able to sustain the gingival level, especially in thick biotype cases. So now, if we look into this again, then we revisit this surgical drill guide system, right? Then we notice that we are using a step down approach to go deeper and deeper into it, and with the final insertion of that. So with the final insertion of that when we put in the implant and we take a PA, we notice that it is actually exactly as where we planned, all right, at the exact position. So now if we revisit again, this was before the extraction. Then we extracted, we enucleated, we take an X-ray, and we place the implant, we put the provisional, and then we place the provisional crown onto it, all right, and preserve the architecture. Yeah, so, and that is actually a very simple case to share with every one of you. So I hope I keep the presentation well within time of 45 minutes, right? So Rolando, thank you very much for inviting me. And also I would like to welcome any questions that the audience might have. Thank you.
Thank you, Dr. Hao, for your brilliant presentation. So while the attendees will think about what they would like to ask you, so I would like to ask a couple of questions from my side. So as you were talking about the immediate implant and immediate loading, and
yes,
all of the time you were on the floor? Huh? Okay, Dr. Hao?
Yes, now I can hear you. Can you hear me?
Yeah, I can hear you. So
okay.
As you were talking about the immediate implantation and immediate loading, so all the time you were talking about the initial torque value. So what's the, so my question would be, how do you evaluate how it is possible to reach your desirable initial torque value?
All right, that's actually a very, very good question, because many people actually ask me about whether we are using excessive torque when we actually achieve about 70 Newton for our primary insertion torque. I would agree that 70 Newtons may seem a lot, all right? So usually the recommended torque is about 40 Newton. But having said that, right, we are using this system, we call it anti-ridge system. The beauty of the anti-ridge system implants is that, as you can see, you actually have a very sharp knife edge here. And this sharp knife edge, right, actually cuts into the bone marrow, the medullary bone here. Whereas the cortical itself is actually a very constricted small head here. So with this small head here, you find that we are not stressing the cortical bone, but instead most of the retention actually comes from the medullary bone, which is actually from the bone marrow. So what's the significance of that is that when we actually have what we call osteocompression necrosis. Osteocompression necrosis, right, is actually an effect that when the torque is too high, that it actually causes the bone to get necrosed, because it is actually a stifling of the blood supply. But in this case, why it doesn't happen is because, right, we're not stressing onto the bone cortical, right? And we are actually stressing on the medullary bone here. And as we know that from the bone density that we are seeing in this case is that the bone density is actually of about D3 or D4 bone because of the granuloma here. So the anti-ridge is a very unique system that actually allows you to gain very high insertion torque. However, at the same time, you do not stress on the cortical bone. So therefore, to answer your question, Rolando, is that how is it that we can achieve a high torque? Is that right? It actually comes from the knife edge, which cuts deep into the bone marrow system. All right. I hope I have answered your question.
Yeah, you did.
Yes.
Thank you for that. And the second would be, does it make any difficulty for you or for the, maybe even for the patient? So when you were talking about the thickness of the guide, so the more the more thick is the guide, the more precise it is. Yeah. So, but when we're talking about the anterior region, so no problems with that. But when we're talking about the posterior region, so more the guide is thicker, So that means the patient has to open his mouth more widely. Am I correct with that?
Yes, yeah, that's a very excellent question. So when it comes to the thickness of the guide, right? So in fact, at the posterior region is always a problem. So if you have a very thick guide here, then you will find that patient has to open very, very big, right? So in this case, right, you find that if you're using a 3D printing technology, at the same time, if we have a very accurate window here, plus a stopper with it, right, we don't really have to have very thick guide here. As you can see here, the thickness is barely 2 millimeter, right? And with the 3D printing technology, it allows us to use a very rigid and strong acrylic block, and then just to print it out in a very, very thin guide. And so we can still have a very strong guide at the same time with the minimum thickness, and still preserve the precision of the implant drill system. So I hope I have answered your questions.
Yeah, so basically, as I understood, the thickest part for the guide should be where is the missing tooth. Is that correct? Yep.
Yes, you are right. Yeah, excellent. Right. So in order to enhance that, we can sometimes actually make a connector, right? A connector when actually help us to reinforce the strength of the guide also. Right, so I'm just trying to show you a picture of the connector. Yeah, this is a picture of connector here. Will actually help us to connect it together to support the edentulous space. Yeah, thank you.
And to use the metal sleeves, that means it's not so important. So you can go with the guy which one is sleeveless. Yeah.
Yeah. Okay. So the metal sleeve, right? As in many other implant systems, they like to use a metal sleeve here.
Yeah.
So, and then whereas for the R2Gate, you find that totally is non-metal sleeve at all. All right. So one might be thinking that without a metal sleeve, it will be less accurate, but with a metal sleeve as a guide is more accurate. But however, the truth is just the reverse. All right. With this 3D printed surgical guide, it actually fit exactly onto the drill. Yeah, so and it also comes with a stopper. So therefore the drill will be fitting in exactly without any hindrance. Whereas when you use a metal sleeve here, right? So as you use a metal sleeve, right, as what Professor Park Jiman has already shown that with a metal sleeve, it appears that we have more precision, but when we drill in, right, that bushing of the drill actually gives us an error about 7.8 degree, all right, of so-called error here. So whereas when we use a surgical guide here with the 3D printing technology without a metal sleeve, you will find that the drill fit exactly, and also the length of the fitting surface, which I would like to show you here, that here for the R2Gate system is 12.5 millimeter, as compared to the most conventional one, which is about only 9 millimeter. So in terms of the fitting parallelism of the surface, it is actually 3.5 millimeter more. And also to add more security, there's actually a flat end here, which will ensure that it fits exactly onto it. And then to even enhance the security, we opens up a door here, a window here, and this window will ensure that all the parallel surface actually fit exactly into here. So therefore, we can actually achieve a precision even up to the hex angle. Right. Thank you.
Thank you. We received a question from the AMI. When you combine CBCT with the STL file from the scanner, is there any different accuracy when you directly scan the teeth in the mouth with when you scan the model with the model scanner?
All right, that's a very good question, Amy. So Amy, let me just go back to this one. Okay, say for example, now here, we actually took a CBCT using a tray here. Now this tray here is actually produced in a DICOM file. Right. So at the same time, we actually have a model here when we do a model scan. So the model scan here, which will means that we actually have this. Let me just show you this one. Oh, sorry, I think I passed already. Yeah, sorry. So this model scan here, yeah, here it is, okay? So you see, we actually have a model, okay, and we also do an intraoral scan. So we did both, the model scan as well as a CBCT here. And you know that we actually has a CBCT with a tray, all right? And then we also pour an impression using the tray, and we also do a model scan of this one. So essentially, our hybrid is in such a way that we also have an STL model. We also has an intraoral scanning of the teeth. And then finally, we reach our hybrid file. So our hybrid file is actually a combination of DICOM, CBCT, STL from study model, STL from the intraoral scanner, and we merge all these three together. We finally get a final so-called file, hybrid file, which will have an accuracy of under 5 microns. So I hope I answer your question, Amy.
I hope so.
Okay.
I hope
Right.
Amy
Yeah.
is okay
Yeah,
with that.
Amy is
So,
from Indonesia. She's a professor from the University of Indonesia, I think.
so we know
Yeah.
each other. Yeah.
All right.
And we have a raised hand from Alvaro Roda, but
Oh, Alvaro. Oh, I see. From Uruguay. All right.
yeah.
Yes,
So
Alvaro. Yeah.
so he's allowed to speak. So if he wants,
Yes.
so Alvaro, if you want, just open your mic and you will be able to chat with Dr. Howe. So if not, I think Dr. Howe, maybe you can just give us your contacts, like an email, where after the whole presentation, everybody will be able to reach you as well.
Yes, I will be happy to do that. I'll be happy to share my Facebook as well as my email address to everyone. And thank you, Alvaro. Alvaro, you may speak up to ask your questions, or you can actually post in the chat group also. Yeah.
So at this point, so I think all of the questions were answered. So thank you, Dr. Howe, once again for your brilliant presentation.
All right. Okay. So may I actually share my my email
Contacts.
address?
Yeah, of
my
course.
contacts. Okay. I don't use so much of the email, so I appreciate that you may find me in the Facebook. All right. So my Facebook is actually How Kim Chuan, just my name, How Kim Chuan. Right, and then you can add me as a friend. All right, okay, and then you can use actually WhatsApp, which I actually also prefer as a social media, and that's actually my WhatsApp contact number. Yeah, so so these are the two ways that you can contact me, either via Facebook Messenger or Facebook itself, or through the WhatsApp. Right, so I very much thank you everyone for giving me the opportunity and attending this simple online presentation.
Thank you, Dr. Howe, once again. And all of the guys, please catch up on all our webinars that you have missed on our official website, www.imegagen.com, and look for and take a moment and wait for our next period of the series, The Moment. So more information will come soon. So thank you, Dr. Howe, once again, and goodbye, everyone. Have a nice weekend. Not a weekend. Have a nice evening. Yeah, that's not Friday.
Thank you, everyone. Thanks. Okay. Yeah.
Yeah, thank you, and see you soon. Bye, bye, bye,
See
bye.
you soon. Bye, bye.